Well, hello everyone. I am delighted to take part in this presentation today. My name is Rebecca Stewart and I am one of the co-founders of Rare Revolution magazine. We are a dedicated rare disease platform to raise awareness for everything that goes on across the rare disease ecosystem. But today I'm here to talk to you about a project that we were involved in called ARDEN, Action for Rare Disease Empowerment. And we wanted to look at lessons learned from the COVID-19 pandemic. At the start of the pandemic, I was approached by Dr. Lucy Mackay, and Lucy is both a doctor and the founder of an organisation called Medics for Rare Diseases, which brings awareness of rare diseases to medical students and medics in training. And Lucy had got some really grave concerns that the directives from government designed to protect us all, protect the NHS, which of course we're not disputing wasn't necessary, it absolutely was, could however have a disproportionate impact on those with rare diseases. So myself, Lucy and Joe Balfour, who's the Executive Director of Cambridge Rare Disease Network, another really wonderful rare disease organisation, looked at how could we document this to ensure that any gaps and of course any opportunities were identified and could therefore be taken into account in future decision making, future policy, and also to feed into the new rare disease action plans. We took a multi-stakeholder approach, and so we invited other patient organisation leaders, pharmaceutical and research representatives, medical professionals, etc., to come together to create a working party which would have the aim of delivering a longitudinal report on the impact of COVID-19 across the rare disease ecosystem. And we looked at three main themes. We had diagnostic delay, health and social care coordination, and research, drug development, and access to treatments, which in right should have been three topics all on its own, but it was we had to kind of condense it down. Now, I personally was involved with health and social care coordination, so I will speak a bit more in detail around that topic. But I do want to touch on the other themes to demonstrate just how widely across the rare disease ecosystem COVID-19 has had an impact. So if we look at diagnostic delay to start with, both disease markers and personal data markers, and personal accounts confirmed that diagnostic delay was exacerbated. And sorry, I've kind of skipped ahead of myself there. What I should have said is the group that looked after diagnostic delay looked across all of these areas. So they looked across pre-engagement, initial consultation, referrals to secondary care, secondary and tertiary care, diagnostic services, and then had a special group of the 0 to 5-year-olds, which is particularly important in rare disease genetic diagnosis. So the high-level results of their findings, sorry, get the right slide on. Data markers and personal accounts from medics that were interviewed, healthcare professionals that were interviewed, did confirm that diagnostic delay was exacerbated across rare diseases. Now, diagnostic delay is already a huge problem within the rare disease field, with the average time to diagnosis already at 4.5 years. So, you know, doesn't take a rocket scientist to understand that further diagnostic delay is a huge problem within the rare disease field. There were a number of reasons for this. The stay at home, protect the NHS slogan was certainly really, really successful in keeping people out of the healthcare system when it was being overwhelmed. However, this combined with people really being worried about contracting COVID-19 from healthcare settings meant less people presented themselves to healthcare. There was also a reduction in primary care capacity and referrals, as well as referrals within secondary care departments. And requests for investigation, a number of investigations performed, were greatly reduced. Also, deviation of all genetic testing to COVID-19 meant requests for these, which are pivotal services for rare disease diagnosis, were either halted altogether or greatly reduced. They also discovered that face-to-face surveillance of children 0 to 5 was greatly reduced. And I think we all probably know someone who's had a baby during lockdown who can speak to that, the greatly reduced face-to-face support that has been available. Now, with 85% of rare diseases having a genetic component and over 50% of those occurring in childhood, early years surveillance is a really essential tool in reaching a timely diagnosis. So what we did want, what was really important to us was that we didn't just show all of the challenges and the negative impacts. We wanted to take these negative impacts and say, well, actually, what are some really strong recommendations that we can make? And the team that worked on diagnostic delay put together these recommendations. So remote clinical consulting optimized. I think that's something we are all seeing now. However, what we discovered from our community was that they didn't want remote consulting to replace face-to-face, and what was a real concern was a disadvantage, either digital disadvantage or because of lack of privacy or some other need, that we didn't need to make sure that any use of technology as a positive doesn't become a negative and mean that there's a disparity that people experience. Enhanced use of clinical information and actions being needed to be taken to identify undiagnosed rare disease patients missed due to the pandemic. So really the idea that a proactive campaign is now needed to make sure that we haven't missed people that we would have normally picked up during that time frame. So health and social care coordination, that was the group that I was involved in, and we had quite a lot to cover in this, so I probably won't pick out all of the findings that we had, but certainly the full report is available from the Cambridge Rare Disease Network website, and the link will be made available to that at the bottom of this podcast so that you can access that. But broadly speaking, we looked at the impact across a number of levels within touch points within health and social care. So we found that the pandemic was compounding already existing problems within the health and social care environment for the majority of rare disease conditions. Widespread disruption across health and social care services. And what we were finding was that the loss of these services, particularly things, so for example, in neurological conditions, where therapies such as speech and language, play therapy, occupational therapies are so important, where these were broadly deemed as non-essential by the government and cut entirely, how essential they are to those with rare diseases is perhaps different. And so what was happening and what was being noted was that there was disease progression, not because of what they would expect to see within the natural history of that disease, but because of the removal of these services. And this is something that within rare disease, once you've lost that ground, you can't necessarily gain that back just when services resume. So that's evidence of disease progression because of the loss of services available is a big impact within the rare disease community. Mental health. Now, of course, 2 years on, the toll of mental health because of this pandemic is being much more widely recognised, and certainly many members of our society will be affected by mental health because of the pandemic. In the case of those with rare diseases, there was the added stress and impact in shielding, very isolating for those that couldn't come, were not permitted to come out of their houses to protect themselves. There was also worry from things like ventilator shortages at the start, where press reports were that those with underlying conditions wouldn't be prioritized. So then, of course, people were terrified of contracting that condition in case they weren't given the same opportunities as everyone else for recovery. So those are all added burdens to mental health. The impact of loss of social care also had a really detrimental effect on the mental health of parents, because along with the loss of those therapies we've just mentioned, there was also the loss of respite services. And of course, with concerns about bringing carers into the home, there was we had all of that lack of PPE. It often meant that parents took the decision to not take up their option of carers to protect their families, and then of course became the sole caregiver for their child, with potentially very complex and difficult to manage conditions. So it became a real cycle of fear, isolation, and then really just exhaustion for families. Again, a compound to this was the failure to meet educational needs that we identified. So whilst absolutely all of us were impacted by the disruption to education and were left juggling homeschooling and work, what a lot of people won't appreciate is that the Coronavirus Act 2020 suspended the government's responsibility to provide educational support to those with special education needs. So now, on top of all of the care responsibilities, education now became the sole responsibility of parents without any professional support to back that up. So of course, you've got that pressure on parents to now deliver another service in home, but also the lack of that support for children with special education needs being provided in a structured, formatted way, the way the rest of us experienced that healthcare challenge. So those with the high level things that we looked at, we also had impact to patient organisations, absolutely massive, of course, when the route to community fundraising just overnight went, no way to raise money through all these events that they would do normally. The attrition to NHS services, with staff being redeployed to other areas, worrying whether they would get them back in time, and what their departments would look like post-COVID. And also utilising technology. There was a real fear from the community that whilst telemedicine is a really positive addition to healthcare services, that it shouldn't replace it. So those were the high level findings that we had. And from that, the recommendations that we felt should be put forward for consideration are really that expert mental health support should become part of the standard careway pathway, or offered as part of that standard care pathway for those with rare diseases. That when some of those therapies and treatments in a situation like this, should it occur again, are deemed kind of the ones that were deemed non-essential, that for those with rare diseases where actually some of those therapies are very essential to them maintaining a level of health, that those should be protected, and so that that broad non-essential blanket doesn't apply to those for whom those treatments are much more essential. And that the vulnerability of patient groups has really been demonstrated through this pandemic, but also the absolutely vital role that they play. They picked up in many areas where the government dropped services. They were often picked up by patient groups, but they were doing it with less money, less access to volunteers if they were shielding, and also, of course, if they'd had to furlough teams to make ends meet. So they were doing more with less people. And so what we would like to see is NHS and government support for crucial patient organisations in the future. The third theme that we looked at was the fragility of the rare disease drug development system. And again, what we saw, what was documented, it was very difficult actually to collect data in this area because not everything was reported. So there was no, if clinical trials, for example, were delayed, there was no need for the companies to necessarily report that. So there was a lot of interviewing done to try and get some of this data on exactly how was that rare disease pipeline impacted by COVID. So as you can imagine, many clinical trials were impacted. And again, whilst this will be true of all clinical trials, whether rare disease or not, what we have to remember is that the number of clinical trials being carried out in any one disease area, rare disease area, is extremely low. And in some cases, it might be the only trial that's being carried out in that rare disease. So to lose those trials is a huge blow to rare disease research. And also, of course, to patient communities who are, looking with hope to rare disease pharmaceutical companies to bring, life-changing therapies and treatments. The disruption of patient monitoring due to patient shielding, not being able to get to sites, etc., affected the validation of biomarkers, and it's a real loss of very valuable data over, quite a long sustained period. And of course, as COVID-19 became this global crisis, funding was diverted to COVID-related research, and therefore less was available from the pot across other areas. Also, funding that might have come from patient organisations was at risk because as their community fundraising came to a very dramatic end, they had less to give. And then there was confusion over eligibility of researchers and scientists for furlough, and also things like animal colonies being shut down to reduce impact there. So again, really widespread disruption right across the rare disease ecosystem. But again, the recommendations that were made here, we have the decentralization of trials and remote monitoring. And I'm pleased to say that over the last 18 months, we've seen a huge, a really huge move in decentralized trials. It's really accelerated something that was coming already, but this has very much accelerated that. And I think that's a really big benefit that has come from the COVID pandemic, is that some of these things which were trickling along quite slowly have been accelerated and have been of great benefit. Virtual sites visits to be encouraged. So again, making sure that within clinical trial protocols, there are the allowance for things like some of the reporting and data collection can be done by nurses visiting the home, for example. And then the encouragement for real-world evidence to be included as an option within the regulatory studies in rare disease. And again, this is another area which has been slowly moving, but somewhat accelerated in the last 18 months, which is really, really encouraging. And there now are some guidance from FDA on the use of real-world evidence in submissions, regulatory submissions for drug development. So I hope that gives you a bit of an overview in how massively really COVID-19 has impacted and continues to impact the rare disease community. For none of us, we are out of the woods yet, and this latest blip has yet again affected us all. And as an anecdote, a colleague of mine who has a rare disease, he's now had 3 of his appointments cancelled because staff have been diverted to the booster programme. So again, rare disease patients are still being affected as the government drives initiatives to fight COVID-19. So we're certainly far from out of the woods yet. So I guess I'll just finish up with this quote, who actually came from our editor-in-chief, Nicola Miller, who is also the mother of a child with a rare disease. So despite the challenges faced during 2020, the rare community spirit of ingenuity and the resilience of all involved in this fight is beyond parallel. So too, in equal measure to the adversity faced, has opportunity emerged. It is time to use this lived experience borne by the rare disease community to build a legacy for future generations as we seek to protect this community through progressive, regulatory, strategic and practical action. Now is the time for that action. From grassroots to legislators, we can all play our part, and play our part we must, because if we do not, we effectively ignore over 3 million people in the UK, and that cannot be acceptable. So I would like to thank you all very much for listening. I hope it has been of interest. There will be more information available to you on accessing the report and some of the organisations that were involved in this report. And please do reach out to me if you have any questions. Thank you.